Okay, well, welcome. I'm Dr. David Beck. I'm at St. Louis University in St. Louis. What I'll be talking about is telepsychiatry. I think the best way to introduce you all to this field is to give my history with telepsychiatry. In 1996, I joined the faculty at MU in Columbia. At that time, telepsychiatry was felt to be relatively new. We had a partnership with Missouri Telehealth Network, and administration was very much wanting to promote telepsychiatry. And the chief of staff approached me early in my days there to do some outreach to the community, especially Fulton, which is about half an hour away, to help out our primary care physicians there. So I did that for a number of years. The second role I had performing telepsychiatry was outreach to a nursing home in northern Missouri who didn't have any other resources in the area. For them, I would do consults half a day every month and provide care for their more psychiatrically intense patients. Another role I held with telepsychiatry was as the director of the intensive outpatient program for psychiatric outpatients in Carrollton, Missouri. In that role, I used telepsychiatry once a month to save the travel to that site, which is quite a ways away. In 2016, I joined the faculty at St. Louis University, and one of my tasks and goals when I came here was to develop a telepsychiatry service here. I was informed that my predecessor had been working on this for 3 years and was close to having things in process, but had just never gotten quite there. It took me about 18 months after I was here to get a service established. And at some points during that process, I was actually told that it would not be something that we could do because of billing and privacy and administrative issues. But we have since been able to develop a service in telepsychiatry. And I'll tell you a bit more about that as we go on. I have no financial disclosures. These are the objectives of the talk. First, to describe the history of telepsychiatry from a more global perspective. Second, examine the current uses of telepsychiatry and potential pitfalls. 3, explain the basic setup that's needed. And 4, discuss the administrative issues associated with telepsychiatry. Objective 1, describe the history of telepsychiatry. I do have a question for you all. How long do you think telepsychiatry has been around? It's been much longer than what you might expect. Telepsychiatry has been in existence for about 60 years. And in fact, the first session was hosted by the University of Nebraska. There have sort of been fits and starts through the years. In 1969, Massachusetts General Hospital used telepsychiatry as an outreach to an underserved population who were served at Logan International Airport. They included children with that. In the 1990s, we had improvement in technology, and so there was improved interest in telepsychiatry. Since the turn of the century, we've had great increases in network speed and some increases in reimbursement. to try to bolster the field. Psychiatry is one of the most active areas of telemedicine, and that's easily understood because psychiatry is well suited. We tend to do little in the way of a physical exam. Most of our diagnoses and treatment plans are based on our history from the patient and family or caregivers, and also our observations of the patient and interview. Expert psychopharmacology is the most frequently requested service. In terms of research findings, telepsychiatry has been shown to be equivalent to in-person interviews for accuracy, treatment effectiveness, and patient satisfaction. Objective 2, examine the current uses of telepsychiatry and the potential pitfalls. The Missouri Telehealth Network, or MTN, started in 1994. They are a wonderful resource, and I frequently ask them questions about various issues that I come up against. They're one of the first public-private partnerships to try to facilitate telemedicine. As Missouri is a very rural state, their mission is to improve care for poor and underserved populations. They have a number of training missions, clinical, technical, operational, and legal. And for the past number of years, they've been hosting a telemedicine summit, usually in Jefferson City in January. Telehealth has gradually expanded. In 2013, there were 202 sites in 62 counties in Missouri. By the end of last year, 100 counties had services. Now, there are remaining 44 counties that don't have services. Most of them are in the top tier of counties in Missouri, just next to the Iowa border. And then the area of southeast Missouri, but not including the Boot Heel. The Boot Heel, interestingly, is covered by providers who are physically located in Tennessee. Our outreach here at St. Louis University has been primarily to that area in south to southeast Missouri. Telepsychiatry, as you will realize by the end of this talk, has a number of quirks associated with it. Medicare has made a number of definitions that really at times don't seem to make all that much sense. But to remember, the originating site is where the patient is physically located during the interaction. It's also known as the spoke or the remote or the rural site. The distant site then is where the provider or the physician is physically located. It's also referred to as the hub, specialty site, referral site, or consulting site. Synchronous telepsychiatry is defined as where there's a real-time interaction between the physician and the patient, which includes audio and visual feedback and interaction. Asynchronous psychiatry is where another provider interviews the patient, that is recorded and then electronically transmitted to a consulting psychiatrist, and then the psychiatrist makes recommendations that are sent back to the primary care physician. We tend to love acronyms, and I found one that I found was entertaining when I was preparing for this. POTS, or POTS, stands for simply plain old telephone system, or just calling someone. Another quirk of telepsychiatry is that the patient, before they're interviewed, has to sign an informed consent form, and there are required components to that. First, that the patient has the option to refuse telepsychiatry at any time. In the years that I've been doing this, I've had maybe 2 to 4 patients simply get up in the middle of the interview and walk out. So that's not much of a problem, and they do have the right to do that. They're informed of the alternatives to telepsychiatry, which would involve travel or not accessing services or accessing what services are available locally. They're informed that there's no storage or dissemination unless they specifically consent to that. They're informed of who is present and the right to exclude anyone and the right to object to taping. When I do my telepsychiatry clinic here at St. Louis University, I commonly will have upwards of 4 students or residents with me. That's not been a problem. I introduce them as learners. Many times it seems as though the patients actually enjoy having the learners in the room, and I've had some patients try to entertain the learners who are with me. I've had a couple of patients who did not want anyone else in the room, and so then I have the learners excuse themselves and go down to the waiting room down the hall. Patient comfort is even more important in a telepsychiatry interaction than even in an in-person interaction. Really need to confirm the identity of the patient so that you make sure that you're talking to the correct person. Sometimes my schedule will get rearranged a bit, so I want to make sure that I'm talking to the right person. I introduce myself and where I'm at. Patients are treated as though they're real and like a patient in person. Everyone present is introduced with their role. And again, I introduce the people in the room as learners rather than getting hung up on whether they're residents or medical students. Anyone entering the room should request permission of the patient and introduce themselves. When I'm doing my telepsychiatry clinic, I do it from my academic office. I leave the door unlocked, and I instruct anyone who wants to join me to simply lightly knock on the door and come in. At that point, I will very briefly interrupt the interview, pan the camera to show them who the patient who's entered the room, and have that person introduce themselves and make sure it's okay with the patient. Patient safety, there are no absolute contraindications to the use of telepsychiatry. I would be somewhat hesitant, though, if there was much of a history at all of any sort of violence or suicidality. There does need to be a provision for emergencies if the patient's in imminent danger to themselves or others. And we have a process where, if that's found to be the case, the local staff will either take them to the local emergency room or call the authorities. And we do have the possibility to have people transported here to St. Louis if that's absolutely necessary. Objective 3, explain the basic setup of a telepsychiatry service. Rooms need to be private. My academic office is at the end of a hall, and it's really pretty quiet here. Avoid windows or glass panels for a couple of reasons. One is for lighting and the problems that may happen with glare, but the other is also for privacy issues. Most of the rooms I used at MU were inside rooms that had no windows at all. There was one room that was located by the entrance where most of the staff came in. So I was careful if I was doing telepsychiatry from that room to make sure that the blinds were closed. Lighting, you don't want any direct lighting because you're going to get problems with glare then. So light should be either on the ceiling or in back of your computer, not in back of you. Noise needs to be controlled. It's best to have a carpeted room, soft furniture, and acoustical treatments. We don't have the benefit of any acoustical treatments here, but again, I'm at the end of a relatively quiet hall. Backdrop should be clean and plain. This is the setting I use for when I do telepsychiatry. It's exactly this, and the patient is recommended to be at least 6 feet from the camera. You want to be able to see their head well, and I like to see their upper torso. I don't really care about the lower body unless I'm concerned about tardive dyskinesia or akathisia. I've had to have people back away from the camera occasionally because all I'm seeing is the top of their head. And the patient also has to be positioned close enough to the microphone that you can hear them adequately. I occasionally have people who are mumbling, and then the staff have to adjust the microphone and that. How should providers prepare for a telepsychiatry interaction? You should avoid wearing stripes. If there's any disruption in the video feed or if the camera gets jolted, if you're wearing stripes, it's easy for the video to appear like a herd of zebras, and you don't want to make people nauseous with that. It's found when voices are transmitted electronically, the volume decreases by about 1/3. So it's even more important to protect your voice. Look into the camera as much as possible and adjust so that the patient can see you well. When I'm doing my telepsychiatry clinic, I am positioned just as I am now. So the video feed of the patient is right up in front of me. I put the other computer where I'm documenting into the electronic medical record just below that so that I'm able to type my notes as I interview the patient for efficiency. And that seems to work pretty well. There is a fair amount of typing while I'm taking the history, but the physical exam part, I have a template such that for the most of that, I can simply choose the correct option and click. Try to avoid looking away from the camera, give ample time to reply. There is certainly a learning curve on that. It's rare, but occasionally the video feed will get dropped and the patient will just freeze on the screen. And so you have to figure out for a while if you need to ask the question again or if the video is frozen or what's going on there. But you can learn that relatively quickly. In 2011, there was a push for privileging by proxy, and it is actually possible for the rural site to say that the provider was privileged where they're at, so we're going to extend them privileges here, but that's on a case-by-case basis. So the rural site, if they decide they don't have the resources to formally re-credential the person, they may go that route. But if they decide they want to be extra careful and privilege them in their own system, then it would require all of this same paperwork. Practically, from my experience, when I came to St. Louis University in 2016, the process to get privileged by them was approximately as rigorous as the process I went through to get processed for Southeast Missouri Behavioral Health to do telepsychiatry for them. Additional documentation that's required in your note: location of the distance site, where is the provider located? That's pre-printed in my template. Second, location of the originating site, where is the patient? CMO has about a dozen different sites that they can send me to see folks in a particular day. They've given me a drop-down menu where I can just choose the correct option for that. CMO is required to obtain informed consent for the telepsychiatry interaction. They then email that to me, and I'm required to keep a copy of that. I've been keeping those electronically. What equipment do you need? Theoretically, you could use Skype, but there are certain standards for encrypting. Camera needs to be able to pan around the room. And this is the room that I'm in. And so usually there are a few more chairs in here and more bodies in here. And then also to tilt and to zoom. Usually some supplemental information is exchanged. When I was doing nursing home consults at MU, the nursing home would, before the interaction, fax me a copy of the patient's face sheet so that we had their correct insurance information, and a copy of the current physician order sheet so that I could upload the medications and the problem list into our electronic medical record. With CMO, I'm documenting into their electronic medical record, so there's very little supplemental information that's exchanged. It's really mostly the consent form that are emailed to me. In terms of quality, you need a high quality, reliable, secure communication. Public internet is not felt to be good enough. You need business grade video conferencing. The internal connections are also important. And if you have to sacrifice anything in quality, then video is much less important than the sound quality. For you techies in the group, these are the technical guidelines. Connectivity, a bandwidth of at least 384 kilobits per second, should be wired whenever possible, and encryption standards are listed at the bottom of the slide there. Objective 4, discuss administrative issues associated with telepsychiatry. Care models are 3. First, direct care. I would consider that what I'm doing with the CMO patients. I see them, give them a diagnosis, and if medications are required, I actually send a prescription to their pharmacy and assume the responsibility for that. Most of what I did at MU was consultation to primary care physicians, wherein I did my documentation in MU's electronic medical record and then arranged for that note to be faxed to the primary care physician or to the nursing home, and then it was their decision about whether or not to follow my recommendations. Collaborative care, when you're working with a nurse practitioner or PA, is very helpful in that the geographic restrictions are suspended. So if you're working with a nurse practitioner, that nurse practitioner can be anywhere within the state of Missouri as long as you're working by collaborative care and telemedicine. What groups are used for telepsychiatry? Kids are growing up surrounded by a lot of technology, and so they're very comfortable with it. Interestingly, kids with autism and pervasive developmental disorders may do very well with telepsychiatry. It places the provider one notch away from them, and so they may feel less invaded by a telepsych interaction. A hybrid model has been developed to manage ADHD, where there's a mix of synchronous, in-person, asynchronous, and education. With that approach, they're able to involve the entire treatment team. The VA has been a major leader in the field of telepsychiatry. In a 4-year period, they had a growth of two times in individual psychotherapy with meds, and med management alone increased by about 1.5 times. The VA over a 4-year period was able to demonstrate a 25% reduction in hospitalization, which was a tremendous cost savings to them. Veterans are exposed to a lot of communication technology in the service, and so they're comfortable with this. And the VA continues to expand their services, now including service in veterans' homes. The third area where telepsychiatry has been bigger is in the correctional system. Texas is the leader in that area. UT Medical Branch serves over 83 locations. Concerningly, only 8 other states are using it, and I'm not sure why. There's a tremendous cost in transporting prisoners and having them monitored while they're in a healthcare setting. It would seem much safer and much more efficient for much more of the work that's done in correctional facilities to be done by telepsychiatry. So adoption has been slower than what it really should be, but we're seeing some growth really out of necessity. There are more inmates who have more medical problems, more mental health problems, and more substance use disorders. The ACLU, however, has criticized this, saying that telepsychiatry is simply trying to cover for not having enough staff in jails. Another area for telepsychiatry is geriatrics. It should facilitate telepsychiatry, but ends up not doing it. So CMS requires that nursing homes provide mental health services to all of their residents. So nursing homes should really be chomping at the bit to get a telepsych provider, but that just doesn't seem to be the case. Barriers would be lack of access. Maybe there's not a psychiatrist available. Do they have a tech person available there? Functional challenges in transporting people to in-person interviews, and then a lack of nursing home ownership. For a nursing home to establish a telepsychiatry clinic, they would need to invest in someone on their staff to be technologically savvy, to work with the equipment. There would need to be a staff person with the patient while they're being interviewed. The nursing home would need to invest in a computer and physical equipment, and they would also need to invest in encryption and video equipment and software. All of that adds up to expense, and nursing homes don't, in general, like to spend money. There's a real need in rural areas for access to mental health providers, and suicide rates are higher in rural areas. So CMS restrictions we'll go through next. CMS or Medicare defines that an eligible telehealth beneficiary is an individual under Medicare Part B, which is fine, that's pretty standard. They require a two-way real-time interaction, have specific requirements for originating in distant sites. CMS has allowed some things such as reimbursement for remote communication technology, chronic care management, and physiological monitoring, as long as they're not called telehealth. So Medicare has been very restrictive. So the originating site, again, is where the patient is, and the patient can only be in a rural health profession shortage area or outside of a metropolitan statistical area. So patients inside the city of St. Louis would not be able to get to access telepsychiatry services. Originally, the originating site was eligible for a facility fee. That's been changed very recently so that the distant site or where the provider is located can get some reimbursement for that. There has been some leniency for end-stage renal disease and acute stroke care. Medicare 2019 allows some new codes primarily for preventive services. These are the health resource shortage areas, and the darker the color, the greater the shortage area. So as you can see from Missouri, again, the northern tier, southeast corner, and then just a little bit in the southwest. Authorized originating sites can be a doctor's office, a hospital, a critical access hospital, a rural health clinic, a federally qualified health center, dialysis unit, a nursing home, or a community mental health center. After July 1 of this year, the geographical restrictions are going to be removed for substance use disorders. I think that's probably in response to the opiate crisis. The distant site, again, is where the doctor or physician is located. Authorized practitioners should be no surprises. The top ones listed there. I find it sort of interesting. CRNAs, they must be doing pain management, and then social workers and dietitians can also be reimbursed. Although insurance companies, private insurance companies are required to cover, they may not pay at the same rate as they do for in-person services. My understanding is in the state of Missouri, they're required to reimburse at the same rate, but I've heard of other states such as New York where they reimburse at half of the rate that they do for an in-person visit. Again, for Medicare to reimburse, it must be an interactive audio video feed that permits real-time communication, and a GT modifier has to be added to the billing code to specify that the interaction was by telepsychiatry. Covered services are pretty standard, listed on the left there. Ones that may be particularly helpful are listed on the right. Subsequent hospital care can be provided, but there's a limit of one visit every 3 days. and subsequent nursing home care can be provided, but is limited to one visit every month. Covered services, psychotherapy, medication management, diagnostic exams, neuropsych testing, and then substance abuse and therapy services. You have to have a synchronous live video to have good reimbursement. Asynchronous reimbursement is really limited. That is done mostly in the forms of grants and contracts, not really by insurance. Email, phone communication, and fax communication are often explicitly excluded from being reimbursed. Medicaid is much more lenient than Medicare in terms of reimbursing telepsychiatry. And 48 states actually cover. In Missouri, the interaction has to be through the Missouri Telehealth Network. The originating site must have staff immediately available. That strikes me as just common sense and the safe way to do these in case there's a problem. When I'm seeing CMO patients, they have a staff person brings them into the interview room, and depending on how busy things are, they may or may not stay with the patient. But if anything is needed, the patient can step out into the hall and get a staff person. Private billing and reimbursement, again, is spotty. Some setbacks and hurdles. There was an act to require that the provider needed a license only where they were located. Currently, the provider needs a license in the state where the patient is as well. That bill died in committee. The American Medical Association has set as a standard one in-person exam, physical exam, as a standard to define the relationship as a physician-patient relationship, and then essentially to give you the authority to prescribe controlled substances. When you start looking into things about telepsychiatry and telemedicine, you will run into references to the Ryan Haight Act. Well, who was Ryan Haight? He was an 18 or 19-year-old man early in the days of the internet who was able to get in contact with an internet doctor who issued a prescription for opiates, which he filled through an internet pharmacy, and he subsequently overdosed and died. So the Ryan Haight Act does not have as its goal to interfere with telepsychiatry or telemedicine, but depending on how your legal authority interprets it, it may interfere with practicing telehealth. A little more relaxed guidance on that I've seen recently is that if there is a provider physically with the patient who is licensed to prescribe controlled substances, then you may issue a controlled substance prescription. Or if the patient is physically located in a facility that has a DEA license, then you may be authorized to prescribe a controlled substance. That being said, there's enough issues and conflicts in that area that even in my work with CMO, I do not prescribe any controlled substances, no benzodiazepines, no zolpidem, Ambien, or other things along those lines, and certainly no opiates. I mentioned licensing before. There are a limited number of compact states. I think there are about 10. And as an example, Iowa and Illinois are compact states. I trained in Iowa, and if I were to get that license up to date again, I would be able to see patients in Illinois by telepsychiatry, but my Missouri license does not allow me to do that. If I wanted to reach out to rural areas in Illinois, I would have to obtain an Illinois license. Again, there's been slow adoption of telepsychiatry and telemedicine. A review of the claims in 2009 showed that there were less than 400 providers that had seen more than 10 consults that year. About a half of them were for mental health. Again, psychiatry is particularly well suited for telehealth, and about 20% of those interactions were by non-physicians. I assume most of those were for counseling. What's our experience been here at St. Louis University? Our court proceedings for St. Louis University Hospital, which is located within the city limits of St. Louis for many years with the city, have been done by telepsychiatry. Within the past year, our geriatric unit has been moved to St. Mary's Hospital, our sister hospital, which is physically located in the county. We are trying to arrange for court proceedings there to be done by telepsychiatry, but are encountering quite a few hurdles, and that's going very slowly. We've been partnered with Missouri Telehealth Network for many years, have the licensing software consents and protocols. Since April of last year, I've been providing service to Southeast Missouri Behavioral Health. They're an organization that primarily treats individuals with substance use disorders, many with opiate use disorders. They have another provider who does the medication-assisted treatment or the buprenorphine and those sorts of things. And I manage the psychiatric comorbidities for those patients. Recently, they've been trying to expand that service more into the community to individuals with primary psychiatric disorders and include them as well. The future includes some resource areas and agreements and cooperative efforts between various states. There's a neat education program known as ECHO, Extension for Community Healthcare Outcomes. It was started by a hematologist in New Mexico. It's based on approximately monthly meetings where an expert in a field meets with primary care physicians in rural areas by telehealth, and they go over challenging cases and have a teaching session. ECHO has a number of areas. My colleague, Bruce Brown, heads the hepatitis C ECHO program, which is based here at St. Louis University. Some things that I would like to see would be multiple site support groups. It's difficult for people to get transported various places. Maybe they don't have gas money. Maybe it's physically difficult to get around. It would be a great way to reach out to older people who are lonely and maybe in their homes or even in nursing homes. There are quite a number of resources available to help with the development of telemedicine. A colleague of mine has been very involved in the American Telemedicine Association, and attends their meetings and finds those very helpful. So to conclude, happier patients are just a click away. I'm happy to take any questions you have at this point. Any comments? Have any of you been able to see any telemedicine being done?
We do have a question here at Southwest.
Great.
I know that there's also some apps that are out, and the American Psychiatry Association has a web page where you can go through and kind of gives you advice on how to grade apps for use, but it doesn't actually list any that they recommend. And so I was wondering if, like, the official position of, in your opinion, of psychiatrists is that telemedicine, like, is it considered a apps that allow a telemedicine type connection, or because there's not a Medicare Medicaid payment model, apps they haven't really been integrated into official use yet?
I don't think apps have been introduced very widely at all. I've had 2 colleagues try to develop apps. I think they've gotten somewhere with that. And legislation just is not keeping up with technology.
Right.
And so it's sort of a quagmire about how regulated that is. There are a number of apps that I do advocate for checking your mood, improving your mood. There's a Headspace meditation app. And there are multiple others that I think are good for people to use personally. An app where somebody communicates with their physician, I don't think, certainly reimbursement hasn't caught up with that. You would need to have some sort of a contract and some way to make sure that that's secure. And there is concern about, so if I upload my health information into an app on my phone, well, how private is that? And I don't know that anyone really knows the answer to that yet. Did that answer your question?
Yeah, thank you.
Any other questions, comments? Not from us. If not, I think we're done for today. Thank you, Dr. Beck, for presenting.
Okay.
I personally found it very interesting. I'm sure it was beneficial to most of the attendees.
Okay, great. So yeah.
So if I get any other questions or anything, I'll send them your way. Oh, there's just a thank you in the chat. I saw something pop up. So if I have any other questions or anything, I'll send them your way.
Okay, great.
I think we are done for today.
So this is an area in development, so stay tuned.
Thank you.
Thanks.